Happy Friday, everybody. Thank you for joining us. Today is yet another iteration of celebrating CP Solvers Legends. Yes, if you're familiar with the more recent format on Thursday, as we use the platform to introduce people to the art of discussion for the first time. And I'm excited actually to emphasize that Friday is that in a different tier, and that tier is sort of the experienced CP Solvers team members who've done this, who are now ready to slip on Prof. Reg's shoes. I think that it is very fitting we have Zakariyya here today, who actually, um, coincidentally, was also part of the new leadership group of 2026. So a big week from CP Solvers to Zakariyya, showing our love and appreciation both for your leadership skills, but also the elite discussion skills you've accumulated. So let me hand the mic to you to say hello. What is not allowed is for you to say anything about me, because people are so bored of hearing that every single freaking Friday. But I'm curious to hear anything else in your orbit, and then we'll shed light on everybody else who's involved.
Hi everyone. Thank you, Rabih. I appreciate the kind words. Yes, I've been currently studying for my HIV diploma in South Africa and learning about M184V mutations of it's been honestly sometimes interesting but quite boring at the moment. So it'll be fun, a nice time to have some fun and switch away from that for a bit.
I guarantee you an antidote to your boredom is a case from our beloved Dr. Rabih. Let me hand him the mic to say hello.
Oh, hi, everybody. Hope everybody's doing well. Really glad to bring another case to this space. Wonderful space where we hear meditative thoughts from Rabih and also Zakariyya, the king of hyperaldosteronism. This isn't a case about hyperaldosteronism, but yeah, I've had the pleasure of co-discussing with Zakariyya. He always does an amazing job.
Oh my gosh, I love that title, the king of hyperaldosteronism. Another thing about this Friday is actually the two people who are making the session happen, Jillian and Vale, who I'll hand the mic to in a moment. Well, neither of them were originally signed up, but both of them volunteered to cover their CP Solvers colleagues within 3.5 seconds of a request, which is just so touching. So let me hand the mic to you guys, Jillian first, and then Vale, and then we'll rock and roll.
Hi, everyone. I'm Jillian. I'm scribing today. Excited for the discussion.
Hi, everyone. I'm Vale. I'm very happy to be here, and I'm doing teaching points.
All right, Rabih, and let's rock and roll whenever you're ready.
All right. So the title of the case, I know Kirtan started this trend of titles, but I call it trick or trait. So we have today a 29-year-old woman with a history of asthma, also sickle cell trait. She came into the emergency department and she's stating that she's having 1 month of cough and gross hematuria, and I'll stop there for discussion.
Take it away, my friend.
Okay, very, very interesting chief concern. And I think if we just go back to the past medical history, the sickle cell trait, I'm just going to put to a side for a moment. We know that patients with sickle cell disease can get a whole length of complications. In patients with sickle cell trait, I don't associate them as having too much risk of complications, besides certain things in the kidneys like renal papillary necrosis, which I know can cause hematuria, but I don't know much more than that. But in this patient with asthma, that's the thing I would specifically focus on, is that, for example, in South Africa, most patients with asthma have a presumed diagnosis of asthma based on clinical history alone and don't necessarily require any further testing for that. We know that you can have asthma, and then you can have asthma-associated diseases. And I won't even want to go into what that differential encompasses, unless there's specific things on physical exam, further history that might make us think that the asthma is something more than just asthma alone, as the base rate of asthma is that I usually will just believe that diagnosis until proven otherwise. And then I think the hematuria for me is interesting, as we know that it's macroscopic, as you can officially see the blood, but we haven't actually confirmed that it's truly from the urine, and especially in patients with that are female that could be having menses, they could be sometimes be mistaken. So I'd want to first actually confirm, is this true hematuria? And if it is true hematuria and the fact that we can actually see it, I find that quite interesting to see in somebody this young. In somebody a bit older who might have a history of smoking and so on, there would be a 40% chance or more of malignancy like bladder CA. But the fact that it's gross and if it is truly hematuria in somebody this young, I find interesting. And try and work up the cause of macroscopic hematuria, I think you'd also just need to first get a bit more on history and physical exam before going down the true differential.
Absolutely super. I have nothing to add. So I'll just, yeah, nothing even to reflect with you. I think you pulled the case as far as you possibly can. So I'll just take a moment to thank the people who've turned their video on. I see Sanjar, Peter, Abdulaziz, and Kiara have turned their video on. Thank you all for hopping on and joining. And I'm glad you're getting a treat of Zakariyya's wisdom. Yeah, let's see where those threads that you outlined get pulled. Mike, back to you, Rabih.
Absolutely. Wonderful start, Zakariyya. So she was having episodes of mild hematuria, also dysuria. Was diagnosed with a UTI previously, thought to have a UTI, given antibiotics without resolution about 3 weeks ago. And then the urine became more and more bloody over the past week, and she had to come to the emergency room, also having a fever during this time. Then this cough got worse the last 2 days, and then she noticed some blood in the sputum, and she also was having some wheezing. She has a history of asthma and has had asthma exacerbations about 3-4 times per year. So she was taking inhalers, and there was some relief. She does smoke, like Zakariyya was asking about. She's never had any sickle cell related issues. She has sickle cell trait, no traveling to higher elevations. We've had a case on that before. No exertional activities, no history of pregnancy in the past. A little bit about past medical history: sickle cell trait, asthma, pneumonia 1 year ago, history of tonsillitis 6 months ago, sinusitis in the past, and then medications. I'll also put that in the chat. So taking fluticasone inhaler, albuterol, social history, smoking history. I don't have the pack per year. There's substance use disorder, smoking, cocaine, crack, something called chasing the dragon, where heroin or fentanyl is also smoked or inhaled. And I'll stop there for discussion.
Ravi, I'm asking myself why I'm so intrigued to follow the hematuria more so than the cough. And I imagine because the hematuria is demonstrable and you can see it versus the cough, I wonder how prominent it is. And I think we may come to regret that if on exam we see that she has such a prominent respiratory signature. Say if she comes in and she's tachypnic and has crackles, we may regret focusing on the hematuria, but the cadence and the tempo of the hematuria starting very slow and picking up and picking up and picking up, it gravitationally pulls you to analyze it very closely. And maybe part of the reason why I'm inclined to spend some time in that space is sort of how different this case is than most patients who come in with hematuria. And a great example for those of you who are subscribed to all our CP solvers is a case that Prof. Rez presented to me that is sort of classic for hematuria, in that most of the time we spend our time thinking about the complications of hematuria rather than the cause, because hematuria often comes in as an isolated, quiet bleeding syndrome without any systemic features. And the fact that this case has such overt systemic features means that you have to sit up and pay close attention to it. We might think our way through that logical conclusion a little bit more slowly. And instead of just applying instincts on what hematuria is commonly caused by, which is what I would do in the cases where it's just the hematuria and there's no systemic features. Here, I might go back and say, okay, I'm just going to ask myself why people bleed. And I think we've talked about this quite a bit of time before. We adopt a simplistic approach to say that there's something wrong with the blood vessel wall, and that's why somebody is bleeding, or that there's actually something wrong with the blood itself. And the reason that schema I find helpful because blood courses throughout the whole body. And so when there's systemic elements to the bleeding, you wonder, wait, is this patient having a coagulopathy or a platelet issue? And that's why they're systemic elements and they're bleeding. In stark contrast, a problem with the blood vessel wall is often either trauma or malignancy-induced angiogenesis. Cancer is making really bad blood vessels that ooze. And so it's much more common for a blood vessel wall issue to be a focal issue, focal trauma, focal cancer. And so if we take this approach to bleeding and apply it to hematuria, I think the fact that there are systemic features has it be very intriguing that the problem might be actually a blood-based problem. But the fact that the patient isn't bleeding anywhere else makes us wonder, well, why would the patient with a blood problem just bleed into their kidneys? And maybe we're wrong about that. Maybe she is bleeding somewhere, and maybe the place that she's bleeding is the other place she's symptomatic, in her lungs, in which case we'd be even more suspicious of a blood problem. But without overt evidence of distant bleeding, we might ask ourselves, how can somebody have systemic bleeding disorder but just be bleeding in the kidneys? And that's where you might wonder, wait, is this the rare situation where somebody has a systemic structural issue? An example of a systemic structural issue is metastatic cancer, which I think I would be pretty worried about in somebody like this, or a widely spread blood vessel wall problem. And the classic example of a widely spread blood vessel wall problem is vasculitic syndrome. Now, if you're thinking about vasculitis as a prominent consideration in this case, it's way, way, way too early. But I don't think you should necessarily ignore the alarm bells when you have kidney and lungs at the same time, because we know if patients do in fact have a pulmonary renal syndrome, the time to diagnosis has to be very, very fast. So Zakariyya, where am I at with the data that we've got? I think I'm really curious what you layer on with the medical history and whatnot, but just the simple reflection of hematuria plus systemic disease has me initially pivoting to maybe a blood-based problem. But the fact that the systemic disease isn't overt bleeding elsewhere has me open to the idea that the patient has a disseminated structural issue with the blood vessel wall, either a disseminated cancer or other blood vessel wall issues. So I can't quite commit to which side of the schema of the bleeding schema we're at, but I'm curious what thoughts or reflections you have.
Epic discussion. And yeah, I think the one thing for me is, honestly, as soon as we heard the word asthma in a 29-year-old, just the fact that it's on a CPS, I'm sure a lot of us started thinking about vasculitis, and the classic one being in this age group with this patient now having sinus symptoms in her lungs, potentially symptoms in her kidneys as well. I'm sure a lot of us were thinking about the eosinophilic granulomatosis with polyangiitis. But I think we can definitely go down that route of hunting for that, sending off anchor serologies and so on. But the fact that this patient firstly has a history of substance use disorder, and I think the other thing is that many of the causes of things that can look like vasculitis but aren't necessarily a true vasculitis are actually more common than some of these vascularities. Makes me really wonder, should we potentially, as you said, look structurally? And the fact that she uses substances, I have no threshold now that this patient needs an echocardiogram, blood cultures, and so on to look for the potential of infective endocarditis. And I think one other thing, just to not jump on that vasculitis schema, is that the fact that the patient actually has had dysuria as well, and the base rate of cystitis being so high means that I really want to see some abnormalities in the urinalysis, renal function, and so on, before I would actually think that there is true kidney involvement in this case.
Moving on to the next aliquot. On physical exam, vital signs, temperature was 100, pulse 104, respiratory rate 20, pulse ox 90%, and room air. Generally young, thin female, moderate distress. She was coughing, now more blood in the sputum. There was some blood crusting around the mouth. On lung exam, mild expiratory wheeze, cardiovascular was normal, abdomen was normal. Flank, she was having severe pain on the left side. And extremities, there was no edema, no neurological abnormalities or any other finding. The skin was fine, no petechiae, no bruising, no trauma to the flank, or no bruising or hematoma on that side as well. And I'll stop there for discussion.
I think a fascinating physical exam, and honestly, the only part that I'm going to talk about is the fact that the patient has flank pain, and I'll leave the rest to Ravi. And yeah, again, just going back to base rate, pyelonephritis is so much more common than vasculitis that this patient has a syndrome of fever, uh, severe flank pain, and dysuria. And the hematuria, especially that it's macroscopic, is a bit unusual. But Rabi brilliantly laid out before why we could potentially be having an issue in the blood itself. And I would wonder if the patient then had a second hit like pyelonephritis on top of an underlying bleeding disorder, if it's possible that she could have some macroscopic hematuria as a result of that. But then just beyond pyelonephritis, it's important to think that there are other structures in the flank that could be the cause of pain. The retroperitoneum is there, and many other GI structures are there as well. And I think it would be really, really intriguing to see what this patient's HP is. And even if she doesn't have a history of, for example, something like melena, is there the possibility that she's not just bleeding in her genitourinary tract, but elsewhere as well? So I think for me right now, with the patient having the syndrome of pyelonephritis, I would be treating for that. But with the atypical features and the other things going on in the lung, going down the full road of working up a vasculitis or vasculitis mimic as well and getting imaging.
Yeah, Zachary, I think that's absolutely superb. I think the flank pain I find, and not to reflect over what you're saying, but I think in addition to the flank pain being as diagnostically intriguing as you just said, it breaks the symmetry a little bit. And what do I mean by that is if you're trying to imagine her lungs and her kidneys affected by something, the fact that she seems to point to her left flank allows you to say, wait, there's a focus of asymmetric disease here, which may be inaccurate. It may be just that actually both flanks are diseases, but for some reason she feels the left more so than the right. But it's a interesting thing about what that does to the calculus, because if we go back to the original schema of is there a structural issue or is there a blood-based issue? A blood-based issue tends to be perfectly symmetric. There's no reason that the right lung is affected more than the left lung in diffuse alveolar hemorrhage. There's no reason that the left kidney is more affected than the right kidney. And so if I'm trying to continue to figure out is this a blood issue or a structural issue, I think the fact that there's asymmetry has me worried that there's a space-occupying process there. And that space-occupying process leads much more to a structural issue. And so why is that helpful? I think if you go into the next phase of analysis and say, if you compare and contrast typical evaluations for patients who are bleeding into blood analysis versus imaging. When you have bleeding dialysis, the blood analysis is the most important thing. What's the INR? What's the platelet count? Who cares about the imaging shows? And in patients with coagulopathy-related bleeding, the imaging is way less important than the actual coagulopathy. In stark contrast, a structural evaluation is all about figuring out where is that cancer, where was that trauma, what are the consequences of it. And so, again, I think what we fundamentally know about her is that she is really bleeding in a lot of places now, and her systemic bleeding is so intriguing to say, oh, she must have a coagulopathy or a thrombocytopenia. But the fact that there's asymmetry, as I'm saying, maybe she has multifocal structural disease. The counter argument to that, I think, is that her lungs seem to be symmetrically affected, and that she's wheezing on both sides. So we'll see how that pans out. But to analyze the pulmonary element, I think I do realize that committing to her hematuria as the focus of evaluation was a mistake, because we're seeing how respiratorily affected she is, both in terms of her work of breathing, her wheezing, and her hypoxemia. So I think I would probably give more weightage to the lungs than the kidneys now, even though the kidneys may be the source of the disease because of how much support her lungs will need. We'll be able to help her oxygenate for her O2 sat, and we'll need to help her ventilate because she's wheezing. And the inflammatory element here is interesting because it just confirms that there must be some systemic process going on. And so after we get a sense of what that systemic process is, I think it might be more productive to layer on the fever. But my mental model of this case is this is a patient who's got unhappy lungs and unhappy kidneys. And I think the phenotype in which that unhappiness is being expressed is through bleeding. And so we therefore know that her blood vessels in those organs are unhappy. And are they unhappy because there's something wrong in the blood coursing through them, or the wall that they have remains to be determined? But I think the fact that there's asymmetry has me thinking that imaging will likely illuminate the case quite a bit. And so what would I do in real life? I would obtain put in a peripheral IV, and no matter who said what about the creatinine in this patient, I think a contrasted imaging will be really, really crucial.
Great, happy discussion about this unfortunate, unhappy case. But moving on to, I'll give you some laboratory data. So starting with CBC, the white count was 11, hemoglobin 9, platelets 180, BNP was normal, renal function normal, coagulation profile was normal. And for the urinalysis is large blood, too numerous to count, RBCs, some WBCs, no proteinuria, and some inflammatory markers. The CRP was 3.58, so not elevated, ESR 40. And I'll stop there for discussion for the next set of data then.
Zakariyya, I babbled so much last time. I wonder if maybe we can hear what you think about this data.
Honestly, I'm looking at it and I'm trying to see if there is anything there that wasn't expected, and everything just feels in keeping with what we already knew, and nothing there really seems out of proportion or anything that's a pivot point to me. I think the one pivot point would be that if Rabih told us that the eosinophils were 5 or something like that, but then again, we also know that many eosinophilic diseases can actually have a normal white cell count, as eosinophils are tissue-based cells, so you don't necessarily will find them in the peripheral blood, even with roaring eosinophilia in your actual tissues. And nothing here really stands out to me. I think that there is some involvement in the kidneys, but the reason for that isn't actually going to be something that I would work up for in terms of just what we have right now. I'd want to get a lot more than that. The only thing I think is that the fact that her coagulation studies are normal seems to rule out a quantitative coagulopathy, and makes me think slightly less likely of something like DIC. I would have expected if somebody had APLS, for example, causing this degree of involvement, you might have some subtle clues with the platelets being potentially abnormal or the PTT being a little bit raised. And I think for me here, it would be what does the imaging show? And I think really we are in that structural bucket, potentially in the heart or in the blood vessels forcing off it.
I think it's superb analysis. I think the things that I'll just say this: when things are negative, they often slip by in terms of being able to get juice out of them because they're so small and subtle. I think the only thing that I feel like really moved the calculus in this case is the fact that there's no proteinuria. And I say that because if you are entertaining a vasculitic syndrome, in which case you might have to move very quickly in an unusual direction, the lack of proteinuria means that the bleeding is not coming from the glomerulus. With the appropriate caveats, this is just one test on a few drops of urine, so it could be inaccurate. But I think the chances of me in real life calling my wife to come help me with this case as a rheumatological one plummet when there's no proteinuria. And I think the value of that too is it just reinforces the previous conversation of weighing, taking a very simplistic approach of bleeding is structural or blood. And I think as you might have predicted, with some difficulty, but might have predicted, the blood here is so underwhelming. There are no coagulopathy, no thrombocytopenia, and no glomerular bleeding. So yeah, I think that it really reinforces that, and I find value in that pretest hypothesis that a structural cause is more likely. And I think a structural cause has become even more likely because there has been no counter argument to it from the blood aspect perspective. And then so now I think we're studying like what's wrong with her blood vessel walls. And I think vasculitis is a little bit less likely because there's lack of proteinuria. And so and take it even a step further to say, if there's a structural issue with the blood vessel wall, what blood vessel is it? Is it an artery? Is it a capillary, or is it a vein? And capillary bleeding from capillaritis or inflammation, i.e. vasculitis, has gone much, much, much lower. So is it a venous issue? And the example of venous issue would be that she has a renal vein thrombosis on that left side, and that renal vein thrombosis has flicked off and gone to her lungs. The arterial hypothesis is that she might have arterial thromboembolic disease from somewhere, such as her heart. The capillary hypothesis may mean that she has angiogenesis from cancer, and that those fragile capillaries are bleeding in multifocal areas. You don't need to speculate on all this because I think taking a look with imaging will be very, very illuminating. And anticipating in advance, if the imaging is underwhelming, where would we go next would be a fun exercise. But why don't we hand the mic to Ravi to take it to the next step, see what he has in store.
Wonderful discussion. You guys do an amazing job. At this juncture, the chat is talking about pulmonary renal pathologies. There's so much murkiness in this case with asthma, the respiratory issue, the inhalational issue. We had to do an autoimmune workup, so I'm going to give you that and put it in the chat as well. So the anchors, I think Zachary was asking, doing the anchors, negative, anti-GBM, negative, complement was normal, not negative, but normal. Infectious, you have to think about that. There's fevers. HIV, of course, have to do hepatitis B, C. Aspergillus, because the asthma was found to be negative. AFB was also, the chat's asking about TB, so preliminary AFB times 3 negative so far. And I'll pause there if this does anything in your thought process.
Yeah, oh gosh, it's amazing how your crystallization of the problem is helpful, but also not so helpful. I'm so, as you've heard me, Zachary, I'm so focused on like what can we see in these organs that getting this data, I'm having to sort of step back and say what value can I derive in it. And I think for me, it just reinforces the idea that glomerulonephritis is a little bit less likely when there's no proteinuria. And then the fact that these are negative reinforces that. It's also great that she's not immunosuppressed from HIV. I find myself stuck in a manual car, unable to shift the gear and can't move forward because I'm like, oh, I really want a picture. I really, really want a picture. That's where I'm at. What about you?
Yeah, it's a tricky one, and I think there definitely was enough of a in terms of the history and physical exam to work up for something like an ANCA-associated vasculitis. This patient has it seemed like quite severe asthma, has had other ENT issues, and now seem to have potentially a kidney issue, but then proteinuria again seem to point against that. Important to remember that some vascularities, like with the one we talked about, eosinophilic GPA, can be ANCA negative and sometimes can then have more severe cardiac manifestation and so on. But I think that's just honestly really less likely. And in this case, I'm now just going back to the fact that this patient had hematuria and an inflammatory syndrome. And I'm wondering about, so we already talked about pyelonephritis. Early on, it came on the patients with sickle cell trait can get a syndrome of flank pain, hematuria from renal papillary necrosis. If I remember correctly, there's something specific about the environment that blood goes through in the kidney that even patients with sickle cell trait are prone to sickling in that specific location. But I think the one other thing is that, as we keep on talking about, is that if there's something structural, potentially something occurring in the patient's heart, and the patient is embolizing from a specific source, that's when the asymmetry, where you can get some asymmetry. And a relatively rare diagnosis, but one I definitely not want to miss in this situation, is the patient having a renal infarction, which certainly can cause severe flank pain, hematuria. We've usually thought a bit of proteinuria as well, and then an LDH can be very useful in this situation. It's quite high and out of proportion to the rest of the labs.
Absolutely superb, Zachary. I love it.
Wonderful job there, Zachary. I'll give you the first bit of imaging. I know everybody's sort of on the edge of their seats, waiting for
Master
some imaging.
storytelling.
But let's start with the chest. So CTA chest, there's bilateral. I don't have the imaging, but bilateral ground glass opacification with mediastinal lymphadenopathy, and I'll stop there for discussion.
Gosh, I think this is fascinating. As we know, the patient definitely has had hematuria, and forget the hematuria, has had hemoptysis. And one of the most common causes of bilateral GGOs that you can see cause GGOs is blood in the alveoli. In terms of what ground glass opacities actually mean, I only recently learned this. So consolidation occurs when the alveoli are completely filled with any material at all. And there's absolutely no air going to that area of the lung, and that's why you get a dense consolidation. In contrast, ground glass opacities, the definition is when there's a hazy appearance where you can still see the underlying bronchovascular tree, and it's caused by some alveoli having disease and being partially filled, but other alveoli being completely healthy. So there's parts of the lung where air is going, and you can see that, and then there's other parts of the lung where there's not as much air, and it causes that haziness. But I think just again, a much more common cause of GGOs than hemoptysis is something like pulmonary edema, and there's the differential of the infectious causes is also really broad, but would most likely seem to be related to the hemoptysis in this case. And again, with the mediastinal lymphadenopathy, it doesn't really change anything for me. I think we were expecting an inflammatory syndrome, but I again, when talking about structural issues, we're talking about endocarditis, also to remember that there are certain cancers that can actually have quite a predilection for the blood vessels itself, like angioblastic lymphomas or angiosarcomas and so on, which can certainly cause the sort of inflammatory syndrome with some asymmetry that we see in the kidneys.
I think that's a superb reflection, Zachary. I think clarifying her lung disease is very illuminating, and I think it's interesting what the combination of these things suggests. So, as you said, ground glass opacities often means there's a liquid in the lungs. Unlike other opacities, like getting a consolidation or even nodules, a consolidation is often liquid as a pus, but it can also actually be solid material like cancer. The same is true for nodules. So nodules can be on the spectrum of solid or liquid, but what's beautiful about ground glass opacities is that they tell you that when you remove that opacity and put it in a tube, you're going to get a bunch of liquid. And it sounds like what that liquid is blood. In contrast, when you take out the excess lymphatic tissue and put it on a slide, you're not going to see any liquid. It's going to be pure solid material. So the question is, well, how do these things jive together? Why would a solid-based structure create all this liquid? And I think that's where there's a little bit of a friction in my mind, and I'm not sure how to make progress. In stark contrast, a very easy CT scan to analyze would be a large cavitary lesion and mediastinal lymphadenopathy, solid, or diffuse lymphangitic spread and lymphadenopathy, solid. So here there's a little bit of a paradox. There's liquid in the lungs and solid in the mediastinum, and that paradox can be rendered by actually saying, well, maybe the lymph nodes are actually just liquid. And that can happen in patients with severe left-sided heart failure. It's classically described and originally described in patients with mitral stenosis who get such bad venous hypertension that they no longer drain their lymphatics. So I see this as a very fascinating CT scan because on the one hand, the most common cause of bilateral ground glass opacities is in fact pulmonary edema from heart failure. And in somebody with a fever who has a substance use history who might have atheromembolic disease to the kidney, heart endocarditis looms large. And then why would her mediastinal lymph nodes be prominent? It might be because she has such prominent venous congestion that her lymph nodes have ballooned up. So that's a reasonable way that they could be linked together. And in fact, it's the only sort of simple way that I can link them together right now. But of course, we'll probably be able to shed much more light on this when we get to see what's happening in her kidneys. And does she just have liquid in her kidneys, or does she have a solid component to this disease? I think that'll help us break the tie.
Okay, ask and you shall receive. So I'll share. I do have one image to share. Okay. And this was a slice of the CAT scan of the abdomen. If I'll pause here for discussion.
Zachary, may I offer just one piece of insight? I think that's a solid, but maybe you can take it further.
Oh gosh, well, I've just started on trying to learn pulmonary imaging with regards to CT scan, but what I can tell you is that there's a marked asymmetry between the two kidneys, and the left kidney seems to be much larger, and there seems to be this massive hypodensity. And if I just use analogical reasoning from the brain, hypodensities in the brain usually mean ischemia and potential stroke. And I could be wrong, but I wonder if this patient has had ischemia to her kidneys, and that potentially is an infarction. But I'm not sure. It could also just be fluid. Does she have massive hydronephrosis? I'm really not sure.
Yeah, I like you. I'm actually struggling to be confident on what this is. It's large. It's affecting exactly where she is. I think the reflex hypotheses are that if it were hydro, it would be so eccentric because it's off center. Um, if it were, I think when you see something like this taking up so much of the renal cortex, you worry that it might be a cancer or a mass. But it looks so simple in the fluid and it doesn't seem complex or multicystic. I think scrolling up and down would be illuminating. Um, yeah, I don't see fresh blood products in it, but I think, gosh, is it asymmetric and large? Yeah, it is. Um, and so whatever this is a structural issue, but I'm having a hard time distinguishing what the structural issue just with this glance. But like you, I'm trying to develop these radiology skills. I'm no master of them, so we'll lean on Ravi for that element.
Wonderful job. Yeah, yeah, definitely. I mean, it's hitting you in the face or in the eyes. There is a left renal mass. There's that adenopathy, 8 centimeter mass, extensive retroperitoneal adenopathy, and there's also a compression of the left renal vein. And yeah, that particularly, I think somebody was mentioning in the chat. Does that remind you of anything?
Go for it, Zachary.
Yeah, I think the possibility of renal cell carcinoma looms large. And if we just go back to the simple illness script for renal cell carcinoma that you should always consider is anyone with an unexplained inflammatory syndrome with hematuria should be worked up for renal cell carcinoma, especially when you start to find other things that unexplained pulmonary disease, a seemingly unexplained anemia, which is quite marked. Her HB is 9, and for her to have hemoptysis that would take her from a normal of 13 or 14 to 9, I would have expected there to be more on physical exam. So yeah, I really think that we need to see if this patient needs a biopsy potentially, and the syndrome seems to fit in with that. I do wonder about the possibility of other things that could affect the kidney. From my understanding, it's highly unusual for other types of cancers to metastasize to the kidney. So if this is a cancer, it's most likely a primary from the kidney itself. And I wonder about the possibility of infections and so on. Could a severe manifestation of pyelonephritis cause this? But I think the most likely diagnosis in this case would be RCC.
Yeah, I'm right there with you. I think sort of go back to that initial model of patients bleeding, structure or blood. Systemic often means blood, but blood is symmetric. And so when you have an asymmetric systemic bleeding process, it often means multifocal structural. And multifocal structural is a buzzword for cancer. Whenever you have a multifocal structural issue, patient has cancer. And so it is a little bit of a leap and a stretch to talk to this patient, hear that she's bleeding, coughing up blood, urinating blood, and then tell you that her left side hurts to say cancer, cancer, cancer. But I think given the morbidity of cancer, I think it's a leap that you should really consider. And so I think this is such a beautiful story being told by a master educator about how the answer is in the history. And it's not that you can talk to a patient and say that you have likely renal cell carcinoma. It's that you can talk to the patient, and the patient's intimate understanding of her body and how she's been suffering can really lead you astray. And so it would be a mistake to see her coughing and wheezing and respiratory distress and ignore her urinary symptoms, because ultimately her urinary symptoms are actually the most powerful. Asymmetric left flank pain is the most powerful clue to this case. So now if we have to try to string it together, I'll tell you, I have a big friction point, because the most common cause of a solitary renal mass is by far and away clear cell carcinoma of the kidney. And she has risk factors for it. There's extensive tobacco use. Question is, what's happening in the chest? And the mediastinal lymphadenopathy, being solid material, is an easy transposition upon the RCC, and the idea that might upgrade the diagnosis in terms of morbidity to metastatic RCC. But how do we think of the ground glass opacities? That's a little tricky. And because ground glass opacities signify the presence of fluid in the lungs, and where that fluid is coming from is interesting. So what I might do is actually go down to radiology, talk to radiologists, like, is this truly ground glass opacities, or are these small nodules? And you'll see that ground glass opacities and ground glass nodules have a lot of overlap. And if the ground glass is sort of spread diffuse, it's more likely to be fluid. But if it's coalescing into tiny little nodules, you actually might be seeing the metastatic propensity, the hemorrhagic propensity of tiny little RCC tumorlets. And so a really astute chest radiologist might really add value to a broadly trained radiologist to zoom in and see, oh, you know what? I see small little nodules that are bleeding. And that's why the ground glass opacities are camouflaging the underlying metastatic disease. And I think that's huge. What Rabih was alluding to is this unfortunate syndrome called nutcracker syndrome, where the left renal vein is compressed by adjacent structures, causing left flank pain. And unfortunately, most people with nutcracker syndrome have benign compression from just vascular anomalies like the SMA. But here, I think this patient has a more malignant version of this syndrome. So I'm right there with you. I think the main concern is this is metastatic RCC. And you wouldn't biopsy the kidney, because the way that the kidney is biopsied often leads increased risk for seeding along the biopsy tract line. And so most localized RCC is actually a radiographic diagnosis followed by surgical resection. But metastatic RCC often requires a biopsy from a distant site to prove it's metastatic. Yeah, I think that would be my leading consideration as well. But we have 15 minutes to learn from Rabih. Michael, you.
Yeah, I was trying to figure out how do I stretch this case, because you guys were acing the discussion. So yeah, we're down to the wire with the final DX. So Rabih, you did a great job analyzing the CAT scan, really diving deep into that. So there was a PET CT done, and it shows pulmonary and osseous metastasis, confirming advanced metastatic disease at the time of diagnosis. So you're right, it wasn't ground glass, it actually was metastasis. And subsequently, a renal biopsy was done, and then I'll tell you why. You're right, with renal cell carcinoma, usually you don't, but the biopsy was done and it showed renal medullary carcinoma. And what was interesting, I didn't know this, was sickle cell trait. We've had other cases of sickle cell trait, but with this case, I think Zakariyya was onto something, and he was describing the environment within the kidney itself. So what happens, the renal medulla is one of the harshest toxic environments in the body. So there's low oxygen tension, it's very acidic, and the urine is very concentrated there. And what happens, even though the patient has sickle cell trait, but like we had a case recently, a couple of months ago, where somebody went up a mountain and had sickle cell crisis because of that, you can get sickling in the renal medulla. And then what will happen is over time, sickling and then infarction and this low oxygen environment turns on growth signals like VEGF and increases the chance of DNA getting destroyed or damaged. And then you also get mutations occurring there. And so healing happens very abnormally and you get malignancy. And there's also this loss of a tumor suppression gene. I think Zakariyya was talking about some genes and numbers. So SMARCB1, which gets lost in this chronic cycle of destruction and healing and so on. And it sets the stage for this cancer to develop. And it's found usually in patients, young patients with sickle cell trait in their 20s, more often male. They come in with very vague symptoms and they have gross blood in the urine. They have flank pain. And when looking at this, so I came across something called loin pain hematuria syndrome. Never really heard of it, but it was interesting in the differential diagnosis. We have a very thin glomerulus and you are prone to bleed, but this, of course, is a mass. And when you have sickle cell trait, do think about renal medullary carcinoma. And also the cognitive errors in such a case, the pulmonary renal syndrome, everything we talked about, GBM and so on. I mean, that comes to mind, vasculitis and so on. I like, Rabih, really honed in like the hematuria. It's not, okay, the hemoptysis is from the metastasis, which you really nicely described. But yeah, the answer was the hematuria and to image that area. Great discussion.
Zakariyya, I'd be really curious what your reflections are about. The biggest reflection I'm stuck with is just how much of a privilege it to be in this space. And I'm sorry to keep tooting that horn, but Rabih has been with us for so many years now. And gosh, when you hang out with somebody, you always feel like you have gotten to know them, but you continue to humble us so much with these incredible cases. And I think this case is incredibly very diagnostically rich, but I was wondering why you were withholding the images until a delayed manner, and I think it became abundantly clear. So thank you so much for such a special hour. I don't think I'll ever forget this story. Thank you. Back to you, Zakariyya.
Yeah, I'm honestly I'm spellbound, and the way you narrated this case allowed us for such an incredible discussion. I think it just really highlights that many of the things that we see and the cases that come to VMR, especially when it's initially presented in the first aliquot, we often can start going down those rare things. And yes, in this case, there ended up being a rare variant of RCC, but the common diseases that can present in such atypical ways and mimic the rare, I think just fascinating, and there's so much to learn about vasculitis, hematuria, and yeah, I think I'm gonna be thinking about it for many days to come. And thank you so much for the opportunity, and really thank you for bringing this case, Rabih.
Zakariyya, I can't wait to tell Prof. Rez this case, to show him how Rabih continues to teach us, but also to tell him how you suspected the inherent pathophysiology of the ultimate diagnosis from the very beginning. Yeah, it's always really cool though, not to just to completely catch it from the first aliquot, because then you've probably learned less, but to be able to add something new to something you already knew, and your pathophysiology of the papillary necrosis, now you can add a little flavor to it and another element to it, which is, I think, the best kind of learning. Well, yeah, I saw you had just finished your sip of your beverage, so we'll hand the mic to you for the teaching points.
No, thank you. It was really hard to, I was just like hypnotized by your discussion and the comments of everyone in the chat. I think it was really hard to keep up with the teaching points. There was so much teaching on this case, but I'll do my best. So I think we began with the schema. Zakariyya worked us through what we should think with someone that comes up with hematuria. And he kind of divided in microscopic versus macroscopic presentations, in which he shared a great pearl, which is that especially when the patient has the risk factors that fit, the age and maybe smoking and other risk factors, to always think about malignancy. So it was really impressive to see that came up from the first aliquot. And that Rabih mentioned why people bleed as an approach to why was this person bleeding, in particular through their urine, and he divided into things in the blood itself, like a coagulation problem or like a platelet problem, versus a vessel wall issue, in which malignancy-induced angiogenesis is something that we should always keep in mind, as well as trauma and vasculitis. And then Zakariyya was also mentioning about the possibility, and I just want to share like 3 clinical reasoning pearls in particular that I thought were amazing. Number one, thinking about, common things being common, and even though this patient had buzzwords were making us think about vasculitis initially, to always think about the possibility of like inflammatory kidney thing being something as pyelonephritis, and like a trigger of an underlying blood issue that is leading to all the bleeding. And then I think one of the main pearls of this case was asymmetry as a clue to kind of lead us away from the initial thoughts that we were having about coagulopathy or like vasculitis. Because if you have asymmetry, that would make us think, okay, this is something that is affecting a lot of things, but it's less likely something diffuse, like a coagulopathy, and more likely something multifocal that would give the component of asymmetry, in which clots and tumors are 2 of the things that we always have to keep in mind. And then also a clinical reasoning pearl is to always get the juice out of negative results and not just like pass through them as negative, and use them to kind of reinforce or decrease our hypotheses standings. And so the absence of proteinuria in this case lowered the possibility of glomerular bleeding and vasculitis, which I think was something that a lot of us, at least myself, I was thinking from the beginning, and it ended up not being the case. And then we talked about the GGOs on imaging, which I think were kind of something that was maybe a confusion, but the coexistence of like something that's liquid as a GGO and something that is solid like a lymph node. And the teaching point here was that lymph nodes can also have a liquid component, especially when there's congestion or like secondary to heart disease, or like a thrombus that increases the pressure. And that can be so great that the lymph nodes can be filled with fluid as well. And then finally, Zakariyya shared about how the renal medulla, because of the environment that it's coated in, is very, very vulnerable to any changes in the blood flow that it receives. And so it's very vulnerable to sickling episodes in patients that have sickle cell disease or sickle cell trait. And this can lead over time to an increased risk of medullary renal carcinoma, which was what our patient had. So yeah, thank you so much. This was amazing.
Wally, it's really, really cool to see a seasoned CP Solvers team member jumping into the teaching point space. You're prompting me to try to encourage more people who've had as much experience as you do to continue to try to do it periodically, because it really shows just how much you've grown and the standards that people can reach. So that was unreal. The clarity with which you taught us and the focus on specific elements was really special. Thank you. Alrighty, I will give you a reason every single day to join the CP Solvers Academy and keep showing up here and present cases. So this is reason 233. Is some of us are very lucky because in an hour we get to hang out and actually watch Dr. Rabih discuss a case. I'll be there. Our beloved AMK is presenting, I believe. So I think I'll see some of you there. Forward to it. Bye, everyone.